With longer survival rates, it's really necessary for us to reimagine a patient's journey. So, we want to focus on evidence-based supportive care, and that means, access the right information at the right time and place. And, when you go from diagnosis through to survivorship, uh, and you facilitate care coordination and emotional support, you'd really drive toward easier workflows and advanced scheduling, etc. So we are using artificial intelligence to really make the journey easier for our patients and being able to help them navigate our environment even easier than they have in the past. When you look at it from an overall patient perspective, right, we want to treat the whole patient, right, because the survival rates are longer. So using AI tools that we're developing, we're really looking at behavioral health, mental health, and how do we provide this support across the overall journey. In today's world, when you think about it, we really want to improve outcomes, right? And overall experience, like we talked about. And we want to help our patients thrive, right? So our ability to process data, when it comes to imaging, genomics, and things that we can maneuver around today is really leading to precision health that's driven by advancing bespoke therapies. So AI is really able to process through all of this data and help us focus, right, on what is the best for a given patient or a given period of time and continue managing them through the process.
Depends on the use case, obviously. So, like, what, for example, one of the use cases we've had is predicting surgery complications, severe complications in our emergency inpatient surgeries. And the way this started was one of our surgeons came to us and said, we're using this surgery calculator that is in the industry standard. Everybody uses it, but it's trained on general population, and I have a sense that it might not work as well for our patient population, which is not only oncology but very specific patient population, even inside oncology, which is we have really sick patients. So the first thing we did is we looked at the risk calculator that she was mentioning, and we did a retrospective analysis of how well it works for predicting complications for our patients. Not surprisingly, it doesn't work very well, and we decided that, okay, we needed a risk assessment tool that can reliably estimate the risk of surgery for our patients. So we trained a machine learning model that predicts the risk of grade 3 plus complications for our patients. And again, historically, we looked at it, it looks good. And then we were able to actually bring it to life by implementing it and having our surgeons actually use this tool. And the way they use it, the intended use is to be able to have conversations with patients and families and have better tools and better data to inform them about their risk. We have a model that predicts with a lead time if a patient is at risk of developing sepsis. And this is for our bone marrow transplant patients. And this is very important because these patients are immunosuppressed. And a lot of times they don't develop fever, which is one of the main characteristics of sepsis in general population. And also because they are immunosuppressed, sepsis is way more dangerous for them. So this model monitors patients, like all of their vital signs, their medications, their type of transplant, everything we know about the patient. We look at it longitudinally, also all of the changes that are happening, and this all flows into the models, and the prediction is a risk score as well as the contributing factors to that prediction. So when we have a high-risk patient, we say, contributing factors like, okay, I don't know, I'm making this up, but blood pressure is fluctuating in the last 24 hours. And this, is something that the model thought would be an indication. So we have something like 5 contributing factors that we surface in our electronic medical record system. And depending on if it's a medium risk or a high risk, there is different people that get the notifications. Like medium risk, the nurses get it. They make sure that they look at the patient more closely and they watch them. And they may order some or ask the physician to order some tests. If it's a red flag, which is a very high risk, so it's at a higher threshold, it goes directly to the physicians, and they have certain workflows that they obviously it's their decision ultimately, but there is recommended workflows for them as well. So this is how it works in the workflows, but also we look at on our end, we monitor these models and we always look at the downstream impact of these models. Like we look at for sepsis, for example, we look at ICU admission due to sepsis, mortality due to sepsis, and we make sure that we monitor these metrics are always moving in the right direction. And we can see a difference before go live of the model and after go live of the model. Obviously, there is a lot happening in the space to improve these metrics. So we can't say 100% this is the impact of the model, but the model is definitely contributing into moving these clinical outcomes in the right direction.